Welcome to HealthWise here on WTVI. I'm Joey Pop. For the next hour, we're going to explore what's new in hip and knee replacement with medical experts from the Hip and Knee Center at OrthoCarolina. We welcome back to our program Dr. Walt Beaver and Dr. Bo Mason. They're here to fill us in on the latest technology, and as always, we welcome your questions by calling us or emailing us during the hour. You can go right now to the Facebook page, the WTVI Facebook page, and send your questions in. Welcome back, gentlemen. Dr. Beaver, good seeing you.
Thank you, Joey. I appreciate everything you do and your show does for our community. It's a great resource.
Thank you so much for that compliment. Dr. Mason, it's been a few years since we've seen you.
It has been. Thanks for having me back.
And since we've seen you last, you have the new Hip and Knee Center at OrthoCarolina with the new location. It's not far from where I live, I must say. So I pass it quite a bit, and it has to be a great resource and building for you right there on Caswell.
It is, Joey. It gives us everything we need to properly take care of our patients. It's a small setting in a relatively large clinic, and people get a really hands-on care for their problems.
And it's nice having 8, now 9 experts in hip and knee surgery working right there together. We can bounce problems off each other, and which is good for patients.
And it's all there part of the hospital district of Uptown Charlotte.
Correct.
It is. It's right in downtown hospital area.
Mm-hmm. Very good. And I would think that patients come in from all over the region, the 2 states, the Carolinas.
It's actually further than that. Our reach goes down to Georgia, to Tennessee, to Virginia occasionally. So a number of people coming from a long distance to come see us, which is great.
And I know this is off subject, but realizing that, is it mind-boggling to you, or is it something that this medical community has strived for years to be the destination that it's become?
Yeah, it's definitely a tertiary care destination for hip and knee replacement. And we get people, like Bo said, from all around the region. Probably more than 50 to 60% of our patients come from outside of our region now for complex problems, for simple problems. They just want an answer from an expert, and we're very fortunate to be able to give them that.
That's exactly what the hour is about. It's going to be an education as to what entails with hip and knee replacement. If you have any idea, even if you have arthritis or if you have a need for hip or knee replacement, there could be some confusion if it's a back issue or if it really is an arthritic hip issue, and all that's going to be part of this education. So they've sent some slides, and let's get right down to it. We're going to start with the knee. So let's go to the first slide, and we're going to show you a normal knee. A lot of these are x-rays and MRIs, correct?
That's right, Joey. And if you look on the board now, what you see is an x-ray of a normal knee. And we always classify the knee as 3 different areas of the knee. You have the inside knee joint, the outside knee joint, and the kneecap joint. And you're looking here at an x-ray straight on, and you can see between the upper and the lower bone a large space. It's black on x-ray, but that's actually your articular cartilage. That's the cartilage or cushion area of the knee.
Next slide. Dr. Mason?
When we start to see breakdown of that cartilage, the articular cartilage is that pearly white structure you see on the end of a chicken wing or a beef bone. And it's a matrix material that is primarily made up of some proteins and water, and when it begins to break down, it wears all the way to the bone, and that is when it becomes very painful.
What is the red that we're seeing around that?
What we're seeing here in the white is that articular cartilage. It should be smooth and shiny, and you see the red and the sort of the pink areas, and that's where it's thinned or worn or eroded. And that is what we see in arthritic conditions.
Let's go to the next slide. The next is an x-ray.
And again, Joey, if you'll look at this slide compared to the very first slide, you see that on one side, the inside of the knee, there's actually no cartilage. You're actually rubbing bone on bone at this point. And you can see on the opposite side of the knee, you still do have some cartilage left.
Which would be on the right-hand side, I'm sorry.
That's correct.
Repeat that, Dr. Beaver.
So on that right-hand side, you actually see worn cartilage where you're rubbing bone on bone.
And it's interesting. You look at this picture, you see where it's whiter on the inside part. That whiter is actually where the bone has become more dense. It's lost its cartilage, and the body has responded by making it more dense.
Now, this is in comparison with the normal knee, the very first slide we saw. So you really do see the difference.
Tremendous difference.
Great, okay. Before we go on, there's the difference right there. Before we go to the next slide, how do you know if you have arthritis? Let's go ahead and address that.
Well, Joey, the normal symptomatology for arthritis is pain, swelling, decreased activity, pain with activity, so you decrease your activity. But pain and swelling would probably be the two most common symptoms we have.
People add sometimes the kind of the crunching, grinding sensation that they'll have inside their knee. They localize it well, just to the front part of the knee, sometimes to the back when you get some swelling associated with it.
So once they have these symptoms, do they go to their family physician, or do they tell their family physician, I think I need to see a specialist?
No, I think that's a great place to start. See your family physician, let your family physician get an x-ray, let them have a chance to treat you. There are a number of things that we can do to help manage arthritis without needing surgery. Obviously, exercise, weight control are things that we think of, nonsteroidal anti-inflammatory medications, a number of those types of strategies. All of those should probably be exhausted with the family practitioner before they need to come to see us.
And by the time they come to see a specialist like yourselves, does that mean they need surgery?
Not necessarily, Joey. Sometimes when they come to see us, there's still some conservative measures we can do, such as injections in the knee, maybe change their anti-inflammatory medications. There's several different types of injections. One is like a steroid injection we can do to calm down the knee. The other is something called viscoelastic supplementation, where we sometimes can inject things into the knee that can actually decrease the inflammatory response, thicken the joint fluid a little bit, and give them a little bit of a cushion there. And it works fairly well in 50, 60, up to 70% of people. But there's some situations where it just doesn't work at all, multiple conservative measures, then you're looking at knee replacement surgery.
All right, let's go to the next slide. And this shows a partial knee replacement. It'll be up in just a second. There we go.
When you looked at that first slide, you saw a knee that looked normal with cartilage in between both. Now we have the situation where in a patient, this patient prior, the wear and tear was just in one of those three compartments on the inside for this particular patient. If it's isolated to the inside part of the knee, if the patient is properly selected, what we can do is this partial knee replacement. It's done with a smaller surgical incision. The recovery tends to be a little bit quicker than with a complete knee replacement. And we're able to maintain the primary ligaments in and around the knee, which is helpful for the knee to have a sensation of being normal in terms of how the patient senses the knee.
Now, all of this is done in an operating room. It is outpatient. Is that what you said?
No, it's typically, most of these procedures are inpatient surgical procedures.
And how long is the procedure? Let's go to the next slide. And this is what it looks like when you go in for such a procedure, slide number 6. And it will be coming up in a second. How long is the procedure? There we go.
The procedure is normally an hour to an hour and a half, depending on the deformity you have to correct. But I'd say somewhere between an hour and a half is a normal operative time for a partial or a full knee replacement. There's a lot of equipment in the operating room. You can see a picture of the operating room here. You see the bed in the middle left, and then all these tables around the bed are sterile instruments that are all for the knee replacement, either partial or full knee replacement.
It looks like a frightening place, but you know, there are a lot of measures that our anesthesiology colleagues take to try to help patients manage getting into the theater. They really often have very little recollection of the time that they spend there.
And as a result, is this considered major surgery?
I think any surgery is major surgery, but yes.
Okay. So do people walk in asking, hey, can this be outpatient? You know, when you talk partial knee replacement, that sounds not very invasive.
Well, around the country, there are surgeons and centers that are doing this as an outpatient surgical procedure, but they're doing it in very highly selected patients. I don't think it's necessarily wise because we tend to see some of our higher complications that can occur at the 24 to 48 hour range. And so it's probably best to have patients in a hospital setting when those things are likely to occur.
All right. I'm glad you mentioned that because we have heard of some some pretty well-known people that have had these type of procedures, and there have been complications. So to perhaps avoid these complications, that's why they're being monitored in a hospital setting?
They absolutely are, and we think that if someone can stay overnight, at least overnight, and if they're functioning well, if they're up and they're independent walking and the physical therapists say they're doing a great job, they're very independent, then probably at that point with pain under control, their therapy is going well, they're independent, then at that point, depending on other comorbidities, they can go home. If someone has a past history of heart problems, pulmonary problems, kidney, liver, whatever, and they have increased risk for complications, we may like to keep them in the hospital for an extra day or so.
All right, how soon are these patients up and walking?
Try to get them up often the same day.
The same day?
The same day. Now, as a part of that strategy, one of the things that patients are most afraid of with any type of major surgery is how they're going to manage pain. We've initiated, with the assistance of the anesthesiologist, a pain management protocol, which is very highly scripted for patients, includes a number of nerve blocks that help maintain, help control the pain. But those same nerves are the ones that power the muscles, so some of the muscles are slightly weaker in that first day. So we have to protect the patients. We protect them. We get them up, moving around. And then as that anesthetic wears off, the next day we can be far more aggressive with the physical therapy.
All right. Let's go to the next slide, and I believe this is a graphic. Explain to us what we're looking at here.
Well, this is an interesting graph, Joey, and the red line represents the number of knee replacements that will be done in this country from now until roughly 2030, and the blue line represents the available orthopedic surgeons that do the replacements that are available to do those surgeries.
I recognize this slide. I think we talked about this the last time you were on.
We absolutely did. And
so you have a concern for this.
Well, we do have a concern for this, and I think what you see now, you see the baby boomers coming into play. The baby boomers are people our age that don't want to slow down. They drive very hard, they exercise a lot, and they wear their joints out quicker, and they don't want to slow down. So they come in and they need knee replacements. At the same time, the available number of surgeons to do those replacements is staying the same, or at least not increasing at the rate the baby boomer are wearing out their knees.
That is alarming.
Yeah, and the health cost allegations associated with that just tremendous. I mean, it's a 600% increase in the need for total knee replacement by 2030. We don't have the resources, I don't know, to be able to cover those right now. We're going to have to be very, very, just have to really work hard to try to figure out how we solve some of those social issues.
So how can we, the lay person and to avoid being a patient of you guys, what can we do to avoid this complication?
Well, that's an interesting question, Joey. I don't want to tell people to slow down, and they're not going to slow down. I think people are going to continue to wear out, but I think it's up to our profession to try to figure out why this is happening, do the research, which we're doing, to see if there's a preventable way to treat arthritis. I mean, if you're developing arthritis, are there alternatives besides joint replacement or other things, or can we reverse the arthritic process? And there are a lot of studies going on, stem cell research and others, that may in the future have an answer to arthritis.
Now we talked about exercise, how exercise could be good for those of us trying to avoid that, but if you're arthritic, how can you exercise if you're in pain?
Well, every good physical therapist will tell you that motion is the lotion for an arthritic joint. So trying to stay active is helpful. Staying active in non-weight-bearing activities, low-impact activities, such as swimming, cycling, those types of things, the ellipticals, et cetera. Keeping the joints actually moving is helpful. It's helpful for the nutrition of the remaining cartilage.
How?
Trying to control your weight.
Yeah, I was going to say weight control.
One of the best things for managing arthritis.
And diet then would have to play into that, but are there certain foods that have come up that you as experts can say, perhaps this is a culprit here?
Well, there are. I think the important thing is that you look at your BMI. You figure out where you are.
Body mass index.
Body mass index. Every time you take a step, just walking, you put 4 times your weight across a hip or a knee. The way I look at that is every 10 pounds you lose is like losing 40 pounds for the hip or the knee. And that gives people incentive. Lose 10 pounds, take 40 pounds off of pressure off of their hip or their knee. So we try to encourage also that they talk to their primary care physician to get ideas about healthy diets. We recommend sometimes some healthy diets they can be on. Some people, Joey, are so overweight that the problem exceeds what they can do on their own. And then we really encourage they get into a structured program, because if you go into a hip or knee replacement and your body mass index is too high, the complication rate is actually exponentially increased, and we don't want to do that. We'd like for people to lose weight first and then be in a safe zone as far as complications are concerned to do their surgery.
Okay. For someone who is overweight and they are told that they need to lose the weight, you're saying, I want you to repeat that if they lose 10 pounds, it's like losing 40 to the hip or to the knee?
Just with walking. When you run, you're putting 10 to 12 times your weight, because both feet are off the ground. You come in with a high impact, and that's 10 to 12 times your body weight across a hip or a knee.
That's amazing. That's something to remember. I hope you can remember that. I'm going to try to remember that myself. We have a call. Shall we go ahead and take Diane from Charlotte? Diane, welcome to the show. Hi, you're on the air. Go ahead, Diane.
Okay. My doctor has told me that I do need a knee replacement.
Okay.
He's been after me to have it for quite a while now, and I keep procrastinating about it. I have a couple questions.
Okay.
One is I have thalassemia anemia. I have always been around a 9.4 hemoglobin. Well, how much blood do you lose, and would I have to have a blood transfusion?
Okay, that's one question. You want to go ahead and give us the second one?
Yeah. I am working currently, and I would like to know, is it more feasible for me to have it now while I'm still working, or when I retire in about 9 months?
All right.
I will be retired.
All right. So can I ask your age?
I'm 64.
Okay.
And my last question is, my knee has made my left leg really bow out.
Okay.
Will that be corrected after surgery?
3 great questions. I'm going to let you take these answers off the air, okay?
Thank you.
Thank you, Diane. Let's first go with the blood loss
Great.
question.
And Diane, these are great questions. And I think the first question about your thalassemia and your hemoglobin, I think that's very important. In people that have low hemoglobins going into surgery, we normally put them on a protocol where they get Procrit, or it's called epopoietin, that can actually increase your hemoglobin level before the surgery. That way you go into surgery with more blood, and you're less likely to have a transfusion. The transfusion rate across the country is probably 10 to 20% with knee replacements. We have some different things we're using in the operating room now, where, first of all, we use a tourniquet with knee replacements on most people. They don't lose much blood. They have a drain after their surgery, and any blood they lose for the first 24 hours, through the drain, we give back to them. So with increasing the hemoglobins ahead of time, using blood reinfusion techniques, usually the transfusion rate, we looked up our last 500 patients, it's about 1%.
And then the second question, she is 9 months away from retirement. Dr. Mason, did you have something to add to that?
No, I was just going to go forward with
9
that.
months from retirement. Should she go ahead and do this now or wait?
I think it's a matter of how she's, Diane, it's a matter of how you're doing with your pain. I think for most people, when you find that you're losing sleep, when you're not able to do most of your activities of daily living, that's when it's time to go ahead and think in terms of doing your joint replacement.
Actually, Diane's still with us. Diane, are you in pain right now?
Well, I have pain constantly, but, you know, when I'm working, you don't think about it. You just do the work. And when you're at home at night, that's when it tends to hit you.
All right, Dr. Mason?
Yeah, I don't think I would. I don't think I would answer this according to your work schedule. I'd answer this more in terms of what your medical needs are. So when you feel like you've reached that time when your life is more disturbed than by your joint replacement, then I think it's time to go ahead and consider having it done. With regard to having whether your leg is going to be straight or not, that's one of the goals of the surgery, is to actually be able to get your leg back into a normal alignment.
Dr. Beaver?
Well, Diane, I think you've asked another important question. You're still working. How much time will you be out of work with this? And that's variable. And some people can't take the time they need to take from work to attribute to rehabbing their knee. And we tell them it's probably best to wait until you have an adequate amount of time. It could be 4 weeks, it could be 6 weeks, depending on the type of work you do, that you can devote to your knee rehab and then go back to work and be very functional.
Diane, I hope this is helpful.
Thank you very much.
Thank you and good luck to you. We're going to stay in Charlotte. We have Eunice with us. Hi, Eunice.
There, Joey.
Hi.
Dr. Beaver was my doctor and replaced my right knee about 12 years or so ago. My left knee got bad right away, and he wanted to operate it on it at that time. And I said, not in this lifetime, because I really hurt. But it has hurt me ever since. Now I'm in my mid-latter 80s. How old is too old to have a knee surgery? And what if you have other health conditions such as heart and diabetes?
Two great questions. Thank you, Eunice, for calling that in. When is too old too old?
Well, we don't look at age chronologically. We look at age physiologically. Eunice may be 88 on paper, but she may be 65 physiologically. So what we do in those situations, especially if they have comorbidities, heart problems or anything else, we have physicians that work with us to go through a very thorough medical exam beforehand, even cardiac stress test or whatever they deem appropriate to make sure that someone is optimized for their surgery.
So before they even go to the OR with you, they know what lies ahead, if in fact it's going to happen because of their health condition.
Yeah, Joey, we're spending a lot, we're operating on older people all the time. Our patients are living older. They have a number of different comorbidities. There was a recent study at Mayo Clinic where they looked at patients between 85 and 100 to see whether their risk from surgery was greater than those patients that were 75 to 85. And in terms of all of the major complications that you would think in terms of infection, bleeding, et cetera, those older patients were not at a higher risk. Nor
With
was
this
their-
study.
With this study, nor was their mortality associated with surgery higher.
And you're talking about elements like diabetes, cardiovascular.
Correct. Now, again, there's some screening, as Dr. Beaver alluded to, that goes into evaluating those patients. If you have somebody that has a number of comorbidities, it may be that we're going to best advise that patient not to have surgery.
Okay, so ease the minds of the public out there. If in fact if they have any question whatsoever, what's your advice?
Well, my advice as far as are they a candidate for the joint replacement, my advice would be to see your primary care physician, let them do a thorough examination to make sure you're healthy enough for the surgery.
Dr. Mason, you want to pick up on that?
Yeah, I think that's good advice. I don't have much to add. I think if you're healthy, active, and ambulatory in your normal day-to-day lives, we can consider you and can consider you medically stable. I think it's good to think in terms of surgery.
All right. There you have it. All right. We're going to be taking our break here in just a few seconds. When we come back, we're going to address the hip. Here we did the knee for the first half of the show. Stick around for the hip. As far as joining this conversation, you see the number on your screen. You're welcome to email me as well, jpop@wtvi.org. If we do not get the emails during this next 30 minutes, you can email me during the week, and I can pass these questions to our medical experts, and they will be more than happy to answer your emails. We will be back right after this short break. You're enjoying HealthWise on WTVI.
An educational grant for HealthWise is provided by OrthoCarolina, a comprehensive orthopedic practice with locations throughout the Charlotte region. And viewers like you, thank you. If you would like support group information about tonight's topic or any other HealthWise topic, call SupportWorks at 704-331-9500.
What's new in hip and knee replacement is what we're discussing here with Dr. Walt Beaver and Dr. Bo Mason from the Hip and Knee Center at OrthoCarolina right here in Charlotte. And we thank you for tuning in. We always have a great conversation with these gentlemen when they drop by to say hello to us here at WTVI in our 15th season. Do you believe it, guys?
Congratulations.
Thank you. We're very proud of that.
You should be, Joey. You're a tremendous asset, and you wouldn't realize how many patients come in and say they saw your program, and they sit by the TV and watch it at night. So.
Well, you're very kind to say that. Thank you. Thank you very much. We would like to think that's the whole mission here with the viewers, that having medical experts like yourself and your colleagues on a weekly basis, it's great to have this hour conversation with what's happening new with medical technology and with these topics that we address each week.
Dynamic.
Yeah, it really is. Okay, let's go to a normal hip. Let's go to the next slide. The phone bank is filling up, and we'll go back to the calls here in just a second. This is a normal hip. What makes it normal?
Well, if you look at, this is a front-on X-ray looking at the hip joint. It's a ball and socket joint. And just like when we saw it with the knee, the space above the ball, that clear semilunar line that's there, is the joint space. And when that space remains open, as it is in this X-ray, we can tell the patient safely that they don't have advanced arthritis.
That's what you want to see.
That's what you'd like to see.
Okay, let's go to the next picture, the next slide.
And this, again, is the schematic looking at a normal joint. And then on the right-hand side of the screen, you see the pitting and the wear associated with the arthritic process.
And then the next one is an X-ray.
And that's what that appears on plain radiograph. Plain
And that's an
X-ray.
arthritic hip?
You no longer see that space above.
You don't
and
see it, do
it's
you?
bone against bone there.
And is that painful?
It can be very painful.
What's the pain like? How do the patients describe?
Most people describe pain in the front of their hip and the groin, occasionally out to the side and occasionally in the buttocks, but very commonly in the groin area. Typically refers down the front of the hip and rarely will refer down as far as to the knee. Now, patients distinguish hip pain often by placing their hand in the groin area or in their front pocket, and if they do, then that's usually emanating from the hip. We sometimes will see patients that think they have hip pain, and it's actually coming from their back, and we'll talk about that here in just a few minutes.
All right. When someone has an arthritic hip like this, are they more subject to having a hip break? We hear so many people that have broken a hip.
Not really, Joey. Unless you have giving way, if something catches in your hip and you fall because of that, not really. People break their hips probably from a fall, although we don't know whether the hip breaks first and they fall or they fall and break their hip.
I was ready to ask that because it seemed that I heard recently that most hip fractures are due to a result of someone breaking their hip before they hit the ground.
I don't think that's actually true.
Okay.
It's a bit of folklore, but you know the process that leads to their susceptibility to the fracture is the osteopenia or osteoporosis, which is a little off what we were talking about primarily with the arthritis. But it is they're more at risk when they do fall of having a fracture.
Let's go to Beverly and Charlotte before we continue. Hi, welcome to the show.
Yes, good evening.
Hi, good evening. What's your question?
My question is, you speak about going to your primary care physician first for a visit. Used to be I would go to my primary care physician and they would say, "Oh, your knee, just typical arthritic knee. Yes, let's give it a shot of cortisone." Went for about a year undiagnosed, and it turned out to be a DVT behind the kneecap. But yet I am now bone on bone on my knee, and I am a candidate for knee replacement. Would you touch me with a 10-foot pole?
All right. When you did you say DVT as
Yes,
deep vein thrombosis? Oh, and that could have been dangerous, correct?
Definitely.
Okay, let's hear what they have to say.
Another great question, Beverly, and we deal with patients with DVTs quite often. The first thing we would do is we would substantiate the DVT by getting a preoperative Doppler ultrasound to see what the vein looks like now, and then we have something to compare that to after surgery. We also sometimes will do blood testing. There are some genetic disorders that can set you up for DVT, and those are treated a little differently postoperatively. After surgery, we put people on blood thinners. We use pneumatic compression devices after the surgery. We have people very active after the surgery, and these are things that can prevent DVTs from progressing. If people have substantial histories of DVTs and or genetic predisposition, we'll even sometimes put removable filters in, so in case these DVTs in the leg break off, they won't go to the lung and cause serious complications.
Beverly, I certainly hope that that helps, and thank you so much for contributing to the show. Let's go out in the region now. Let's go up to Catawba County. We have Nicole with us. She calls from Newton. Hi, Nicole.
Hi, Joey. How are you?
I'm great. How are you?
I'm doing okay. Could be better.
Well, we have Dr. Walt Beaver and Dr. Bo Mason here from OrthoCarolina. How can they help?
Well, I have osteoarthritis of both my knees. I'm not but 31 years old, and I also have 40% damage of my joint in my right knee, and I'm sitting at 35 in my left. What can I do to prevent it from progressing? Plus, am I a candidate for knee replacement?
All right. Once again, can I ask your age?
I'm 31.
31. Okay, we're talking about a young person here. Who wants to take this question? Dr. Mason?
I'd be happy to. Nicole, we try not to do joint replacement in someone as young as you for a number of reasons. We look at these joints as a temporary improvement, a temporary up to maybe 20 years of improvement. And someone who's 31, it's unlikely that we're going to be able to get you all the way through with one joint replacement. So we like to try to delay that surgical intervention as long as we possibly can.
How long is it going to last?
As I mentioned, usually about 20 years is what we'd like to be able to see from a joint replacement.
Okay. So that puts her at 50-some by the time, if she should have it done now, and she's still a young person. So that's why you try to...
Trying to delay that intervention. Now, certainly we do have the option of doing revision surgery, and there are rare exceptions when we need to do joint replacement on somebody of that age. What I would want to do if I had Nicole in the office is explore what other options we might have to manage her pain with regard to some of the injections, weight control, exercise programs, et cetera.
Don't ignore it.
To try to push that as far into the future as possible.
Nicole, thank you so much. We're going to head over to Anson County now. In Rockingham, Ted is with us. Hi, Ted.
Hi.
What's your question?
Yes, I've had my tears in my knees, and I've had both of them. Both of the tears came about the same time, so I've had them both replaced, worked on. But what I want to ask you now is, it's came back. It's reoccurred in both my knees, and I'm in a bunch of pain. And meniscus tears, that's what they call it. And but I ain't but 49 years old.
Right.
And, I was wanting to know if ain't there a new type of knee replacement, like insert in between your knees or something, keep your hand from bone on bone till you reach the age of retirement where you could have it done.
Ted, thank you for the call. Let's hear what they have to say, okay? We're talking about another young person here.
Yep.
Yeah.
Ted, 49 I consider extremely young, and it's getting younger. The meniscus tears you talk about can be associated with arthritis. It could be part of the arthritic process, or it could be like a sports injury where you just tear the meniscus but you have no other damage to the knee. It sounds in your situation like an arthritic-related meniscus tear, and you have to be very careful with those. You don't want to go in and have arthroscopic surgery if you have significant arthritis in the knee, because it will not take care of the arthritis. You allude to probably something called unispacer, where there are some spacers that you can insert in the knee. Those are not used very commonly anymore. There was a fairly significant complication rate related to unispacers, and if the arthritis is severe enough and your activity level is decreased enough, possibly you are a candidate for a knee replacement. It's hard to say unless we saw you or had x-rays to see how you were doing.
Ted, good luck to you. Let's go back to the slides if we can. I believe the next is an MRI of the spine, and why is this important?
This is an X-ray looking at the spine, and you can see between what's labeled 4 and 5 on the screen. That's the fourth and fifth lumbar vertebra, there's a bulge that goes out towards the right, and that's a disc that's herniated and is pressing against the nerves, which you can see highlighted in the white with the red arrow. Those nerves, when inflamed in the back, particularly the upper lumbar spine, can lead to pain that is confused with both knee and hip disorders.
So how do you tell the difference?
There are a number of different physical exam techniques that we can use in the office to help distinguish the pain. But for a patient, before you get to the office, if your pain is in your back pocket, then it's typically coming from your back. If it's in your front pocket, it's typically coming from your hip.
Okay, so tests like this, diagnostic MRIs like this, tools like this will help the medical expert like yourself know if it's hip or if it's back.
Absolutely.
That's so important, because I guess there's so many people out there that are wondering, well, is it my hip? Is it my back? So these MRIs are sophisticated enough to tell that.
Well, they are, but prior to an MRI, usually by clinical exam, or even by listening to the patients, you can tell if it's a back, if it's a hip, or if it's a knee. And sometimes, when people call in and they explain their problem to our appointment schedulers, they'll sometimes redirect them to our spine center, because people sometimes get upset if they come to see me or they come to see Dr. Mason and it ends up being a back problem that's a little out of our realm of expertise, and we have to send them on. So we try to do the best we can by triaging these calls to the correct subspecialty center.
Can be confusing, can't it?
Can be confusing, yes.
All right. Let's go to Matthews. We have Laura with us. Hi, Laura. Welcome to the show.
Hi there.
What's your question?
My question is that I have a good friend who has been diagnosed as badly needing a right hip replacement. And we've done quite a bit of research. And we would like to know about the benefits of the anterior approach for hip replacement as opposed to, I think, the lateral or the posterior. And are there any negatives that you could tell us about the anterior approach?
Good questions, and I think they're going to get into this too. So let's go ahead and address it, can we?
Well, Laura, there are a number of different ways that we get into the hip when we're trying to place one of these devices here, and we'll show you some pictures here in just a few minutes of a hip replacement.
We're going to go ahead and show it right now. If let's go to slide number 12. This is a hip replacement, and stay with us, Laura, if you will.
But
Laura, I will indeed.
What we've and this is a hip, which is a hip replacement, a device that goes down into the femur, and then a socket that is up in. The femur is the thigh bone, and then the socket, which is up in what we refer to as the acetabulum, and it replaces the ball and socket of the patient. So that's kind of what we have here is a socket here, a ball, and a stem. Right. How we get that in really isn't as important as how well it's put in. Trying to get this properly oriented so that it's fixed within the body. Is the most primary concern of your surgeon. There are benefits potentially to surgery done one way versus another. What those exact benefits and what the risks associated with those are still being sort of investigated at this point. All the surgeons at OrthoCarolina Hip and Knee Center have experience doing anterior approaches to the hip. Not all of the surgeons do anterior approaches to the hip, and I think what's most important is to try to figure out what is your surgeon's preference, because you want your surgeon to be doing what is he feels best doing and what he does best for you. Now, with regard specifically to the anterior approach, it's an old approach to hip replacement surgery in which the surgeon utilizes an interval between some muscles in the front. It may have a lower dislocation rate, and properly applied, I think that's a benefit for patients. I think the other risk is it's a relatively new surgical approach. It's important that your surgeon have experience doing it. If they're not experienced with it, their complication rate indeed may be higher. So it's you need to select your surgeon, I think, more than how you have your surgery done.
And should patients ask these questions when they go to these surgeons?
Absolutely. I think asking there are a number of questions that you should ask. And Walt, maybe you could address this, but in terms of what criteria patients should know about a surgeon before they come in for a joint replacement.
Dr. Beaver, let's address that. How can you help the viewer out here ask the right questions when they go in for consults?
Laura, that's a great question about your friend, and we do have preferences: anterior, posterior, posterolateral. And I think if your surgeon is comfortable with the procedure, I think your outcomes will be very good. I think that it's important to realize that probably greater than 50% of the hip and knee replacements in this country are done by surgeons that do less than 10 a year.
Oh.
And I think I always use the analogy, it's somewhat like playing golf. If you play golf quite a bit, you're going to be watching someone on Sunday afternoon on the PGA versus someone like Dr. Mason and myself who don't play golf quite as much. We're not as good at it. So I think it's always good to know the experience your surgeon has, because the more experience they have, the volume that they do reflects in the decrease in complication rate.
So if you go to a surgeon, be sure and ask what procedure he's more comfortable with.
Don't be embarrassed to ask those
Don't be
questions.
embarrassed to
Yeah.
ask. And if I have question, well, how does this procedure compare to this procedure? Can you refer me to an expert that can answer the questions on this one?
Absolutely better.
That's not going outside the
part of-
box?
no, that's-
Where it's
and
going to
that's-
offend a doctor?
No, I don't think so. And that's the benefit of having a center like we do, where we can reflect those types of questions and look at these and try to answer those internally. We're in fact doing a research project right now to try to answer her question as we speak, whether it's better to do this procedure as an anterior approach or whether it's better to do it as a posterior approach.
Let's make sure we fully explain the approaches here for viewers that might have just tuned in.
The approach is simply, and I think there's more importance, I think, placed on the approach in the lay literature than there should be. But the approach has to do with simply how the surgeon accesses the hip joint.
Whether it's from
Whether
the
it's-
front or the side or the
Whether
back?
it's coming in through one particular plane or whether it's coming in through another plane into the hip joint. The potential advantage to one approach is that it may not take down as many of the muscular attachments to the bone and thereby prevent dislocations from the hip. Dislocations tend to be one of the higher complications for patients that have well-fixed components. Now, one of the things that helps prevent dislocations is having accurately placed components. How do you get accurately placed components? You have a surgeon who's used to doing the surgery.
Does that help, Laura?
Oh, indeed it does. Thank you so much.
Thank you. We appreciate the call. We really do. Let's go to the next couple of slides, and then we have some more questions here to ask these doctors. Hip dislocation.
Well, Joey, the X-ray you see shows a normal hip on the right side and a hip replacement on the left side that's dislocated. You can actually see the ball that's attached to the stem going down the leg is out of the socket now.
Oh my gosh, is that painful?
It's extremely painful. It's extremely painful. It happens in probably about 1% of hip and knee replacements done in the country.
How does it happen?
Usually it happens with the patient getting into an abnormal position that puts torque on the hip replacement and levers the ball out of the socket.
Let's go to Hickory now. We have Vivian with us. Hi, Vivian.
Yes.
What's your question?
My question is, I am 77 years old, and I do have osteopenia. I want to know what the doctors think of cement for a hip replacement at my age, and is cement mandatory for Medicare payment, or is it contingent upon bone condition?
All right, good question.
Very good question, Vivian. The osteopenia is a common term used to say you're within one standard deviation below normal for your age. Osteoporosis would be 2 standard deviations or more below as far as weakness in the bone for your age. Medicare does not stipulate what type of fixation we use in patients depending on their age or bone quality. They leave that up to the surgeon to decide whether we can do a hip replacement without cement where the bone grows in or whether we need hip replacement with bone cement. And a lot of times we know most of these situations by looking at your x-rays beforehand. Sometimes we make the decision intraoperatively. We have all of these prostheses available to us in the operating room, so if we do get into the surgery and we decide that the bone is weaker than we thought, we can make those changes in the operating room, but normally we know ahead of time.
How about Medicare?
Medicare does not stipulate what type of hip replacement we use.
I hope this helps, Vivian. Okay, let's go to, yes, thank you. Steve and Charlotte, welcome to the show.
Thank you.
What's your question?
Well, I have a couple of concerns. I'm 54 years old, and I have osteoarthritis, but I've seen numerous specialists, and my concern is multiple questions, actually. I have one leg that's longer than the other, and thus it's knocked my whole spine out of whack, but I'm bone on bone in my hip, so it's creating a very severe pain towards the groin area, but also the fact that the one leg is longer. How do they make it so that the legs are even? Is there a way of doing that so it can alleviate the problems that I have with my spine at the same time with my hips?
Let's hear what they have to say. And you say you're 54, so we're talking about a young guy once again.
Well, I think I'm young, but I played a lot of hockey. So
Let's hear what they have to say. Thanks, Steve.
Thank you.
Steve, you're extremely young, and in situations like this, what we do is we take an x-ray in the office. We have what's called digital x-ray, and we actually do your hip replacement on the computer before we actually do the replacement on you. And we have ways to determine leg length discrepancy, and in the operating room, with our techniques we use, we're able to restore leg length. And a lot of times when you equalize the leg lengths, it does take a lot of stress off of your back.
But I would add, Stephen, it's very difficult for us to actually make a leg, as it sounds like in your situation, to make a leg shorter on the side that has arthritis. That puts you at higher risk for having the complication of dislocation. So I would guess that unless your leg was shorter from the time you finished growing, that your leg is actually not longer, but you have what's referred to as pelvic obliquity, when the spine is curved and the pelvis is higher or lower on one side, and you perceive the difference as one leg being longer or shorter than the other.
All right, Steve, we thank you. We hope that you can get some help. It's been in the news lately where some of these implants have been recalled. Why does that happen?
Joey, a lot of hip replacements function very well. There are some newer technologies that come out that are used because people want state-of-the-art, and we're always trying to improve joint replacements. If we find, across the country, in large centers usually, if we find by following our patients carefully that there's a higher complication rate, such as loosening of the prosthesis, bony ingrowth not occurring, then sometimes the companies will look at these and say, wait a minute, we need to recall this, we need to rethink this, and look into why these are failing at a higher rate than the older hip replacements.
And when this becomes newsworthy, it's very alarming to people, especially for those who have had the replacements. I guess the switchboard lights up.
Yeah, it's very alarming. And it's interesting, to Dr. Beaver's point, we got this information from a registry or a study that was done in Great Britain. We had used a few of those types of hip replacements in the Charlotte area, it really only in selected patients, and for a rationale that we felt pretty convinced about. But so there were not a large number of those done here, and we didn't do any, haven't done any since about 2007. We recognized issues, but we have no national database and a national registry of joint replacement, so it takes a while for the information to begin to sort of trickle through the investigative process to understand whether there is a problem. I would say this is a voluntary recall by the company. It doesn't excuse the potential injury to patients, but we've made efforts to get out and get in touch with every patient that does have that type of an implant. Reach out, let them know what resources are available. And what most people should know is that the vast majority of those patients that have that type of an implant are functioning quite well.
All right, good to know. Had to ask that. Let's go to the last slide. It's a hip fracture. And this is a result of, this is after a procedure, after a hip replacement?
That's right, Joey. What you see is one of the complications. With any surgery, there are always risk and complications. One of the risks and complications from hip replacement, besides dislocation, is a fracture. This particular fracture came from wear of the plastic. Sometimes the wear of the plastic can weaken the bone, and with any type of trauma or fall, the hip can, the bone around a replacement can fracture. We call this a Peri prosthetic hip fracture. These are relatively uncommon and can be treated appropriately so people do well after a traumatic complication like this.
Joey, this is a good point. We had one caller that, earlier who was 31. The longer the implant is in the patient, the higher the risk of having a complication.
Why is that?
And it has to do with the body's response to the wear debris particles, the particle load that occurs at the bearing between the ball and the socket. The body really doesn't quite understand what to do with those particles. It tries to essentially vacuum them, and it's not successful in doing that. It eludes these proteolytic enzymes that can eat the bone. And over a long period of time, with older designs of implants, we've seen bone that becomes very weak and risks fracture, like in the X-ray that we were looking at.
Let's go over to Mount Holly. We have Dolores with us. Hi, Dolores.
Hi, Joey.
How are you tonight?
In pain.
Uh-oh, let's hear your question.
My question is, 3 years ago, I had back surgery. Well, I seemed to do real well, and then I started having pain in my right side and down my hip, and I wondered if I had the right kind of surgery.
I would think so.
Okay. I am going back to the doctor Tuesday. I've had enough x-rays to wallpaper my bedroom. So I don't know. I just feel so ignorant about all of this.
All right, so you had a back procedure, and now you're having some pain. And are you questioning if it's perhaps an arthritic hip?
I know I have osteoarthritis, but I'm wondering, could this back pain be from a hip problem?
Let's hear what they have to say, Dolores, and thanks for calling in from Mount Holly.
Thank you.
Dolores, that's another very good question, and we have people that come in daily that have had back surgery and their hip hurts. Most of the time, they've had very successful back surgery. We have very talented back surgeons in this region of the country, and they actually end up with arthritis of their hip. So you can have two things going on. You could have back surgery that's very successful and then develop pain in your hip from arthritis. You can also, after back surgery, have other problems in your back that may not be related to back surgery, more arthritis in a different level that could be affecting your hip joint. So the important thing is that your spine surgeon look at your hip, look at your back, and they should easily differentiate which is causing your pain.
And whenever they pinpoint where that pain's coming from, can she be helped even though she's already had a procedure?
Likely. Properly diagnosed pain in the back can be managed well.
Okay, just because she had a back procedure doesn't mean that she can't have...
necessarily has a failed back or anything along those lines. It's, again, the specialists that we have working in the spine center at OrthoCarolina do a great job of parsing out where that pain is coming from and addressing it.
Wow. Well, the hour's gone, guys. We filled the mission of, we were talking about that you guys are really the educators and we are the students, and we really do absorb this information. We are calling this show the Hip and Knee Replacement Part 1 because we're going to have Part 2 on this same topic in the next few weeks. So we thank you so much for being here from the Hip and Knee Center at OrthoCarolina, Dr. Walt Beaver and Dr. Bo Mason. They're right here in Charlotte, and for more information, you can certainly go to our website, which is WTVI.org. It has a physician's directory, not only for this broadcast, but for many of the shows that we have across our board, and with this new season here in front of us. We also have the podcast. If you should have missed this show, you can go on the website and see the entire show. Now, if you didn't get your question in, email me, jpop@wtvi.org. I'll get it to these medical experts. As always, we hope that this medical broadcast has helped you become more health-wise. Make it a great week.
If you would like support group information about tonight's topic or any HealthWise topic, call SupportWorks at 704-331-9500. If you have a comment or question about HealthWise, call 704-371-8836 or email us at healthwise@wtvi.org or go to the website wtvi.org. If you are interested in being a guest on HealthWise or like to sponsor a HealthWise program, please call Suzanne Milkey at 704-372-2442. Learn more about HealthWise and other local productions at WTVI.org. Go to our website and you will see current and upcoming events on air and in the community. That and much more at WTVI.org.